Hello, everyone. My name is Yesim Dargaud. I am professor of hematology and head of the Lyon Haemophilia Center in France. It's a great pleasure to welcome you to this webinar organized as part of EHEAD e-learning program. Today, I'm joined by a very distinguished hematologist, hemophilia expert, and a friend, Professor Maria Elisa Mancuso, from the Milan Humanitas University and Research Hospitals. So the purpose of the webinar today is how we manage surgery in patients with hemophilia. And today we will gonna talk about patients without inhibitors, and we will meet you again next month to talk about patients with inhibitors. So this is the agenda of the webinar, and we'll get started if you are ready. Maria Elisa, how do you organize surgical procedures in patients with hemophilia?
Thank you, Yesim. Yes, my task is to show, or let's say to discuss together, which are the best practices for managing surgery in patients with hemophilia and, as you mentioned, without inhibitors today. So what's essential is to have a good plan. So this can be somehow maybe needless to say, but we do need to have clear the situation prior to start surgery. Someone may argue that this is applicable only for elective surgery because we have to distinguish between elective and emergent surgery. But I would say that a sort of planning is also needed when you have an emergent surgery, meaning that you have to know which is the process and somehow have in mind some key questions that can also be applicable in the emergent situation. And first of all, we have to take into account which kind of surgery we are looking at and which is the surgery needed from the patient, and basically know which is the bleeding risk associated, because we have major surgery or really also in the frame of major surgery, some interventions that even in non-hemophilic people are at very high risk of bleeding, and we should take into account that. In particular, looking at patients with hemophilia, then we need to know which are the levels of either factor 8, factor 9 that are needed to ensure a good hemostasis in the situation of the surgical setting. About the patient, of course, what is needed to be clear is the situation of the patient. Now we are talking about patients without inhibitors, but still it's very important to know if in the history of that given patient there is or there was an inhibitor in the past, because this may impinge upon the response, the PK response, so the pharmacokinetic profile and response of that patient to replacement therapy. And if possible, I mean, I don't think it's always mandatory, but it may be really helpful to know which is the individual pharmacokinetic response to the drug of that given patient, because we know there is inter-individual variability in the response to factor 8, factor 9, related to the, let's say, individual clearance of factor 8, factor 9. But we know also that in the same patients, it's rather reproducible over the lifetime. So if we know that that patient have that kind of in vivo recovery and then the half-life, so the ability of factor 8, factor 9 concentrate to stay in plasma is around 12 to 18 to 20 hours, this will be somehow reproduced during the setting of the surgery, even though also we have to take into account that at the very beginning of the surgery, the consumption may be a little bit higher. And so we may have a decay curve, which is a little bit different from, let's say, a PK profile studied in a non-bleeding state. So having said that, we can also plan how to treat these patients during the surgery. For instance, to decide if it's worthy or, let's say, more convenient in terms of protection to deliver the drug by bolus injection or continuous infusion, and how to monitor. So what is also important is that we should have a good amount of drug to be used and to cover the surgery, and we should have a lab available to tell us exactly what we are doing to the patient. So which is the response and which are the levels that we get in the surgical setting, both intraoperatively, but also in the post-operative period, because we should ensure a good hemostasis virtually or theoretically until wound healing. So, looking at the bleeding risk associated with the surgery, there are several, examples, or maybe let's say categorization of different procedure. Here you can see that we can somehow distinguish between major and minor procedure according to the type. So usually we say that if we are going into a body cavity, so we are somehow discontinuing an anatomic barrier, like we are going into the abdomen, the thorax, or even we are going into a joint, which is pretty much common in patients with hemophilia. So having major joint replacements. These are all major procedures. For minor, let's say that all the procedures requiring general anesthesia, they are considered all major procedure, and usually major procedure come with a high bleeding risk. So, for instance, in hemophilia, if we think about orthopedic procedure in terms of arthroplasty, we should also, treatment of pseudotumors. The removal of big pseudotumors, they are, of course, at major risk. We can consider minor procedure all that maybe they do not need general anesthesia, they do not, let's say, invade body cavity. So let's say also dental procedure or other the skin procedure, they can be considered minor with a much less bleeding risk. Although sometimes also we should take care of that, because we all know that, for instance, if we have a complicated tooth extraction, even though only just of one tooth, the local situation may need a good coverage because of the local situation. So, about the level to be maintained, we have guidelines. This table comes from the third edition of the World Federation of Hemophilia guidelines. They suggest us which are, let's say, the ideal levels to be maintained in plasma for patients with hemophilia A, hemophilia B, according to the type of procedure and according to the timing. So looking at the first, let's say, 24 to 48 hours, we need to provide, let's say, rather high levels because of the consumption I was mentioning before. When we have the initial part of the surgery, a coagulation is activated, there is a little bit more consumption, then every new day after the surgery, we have less consumption because the healing process starts. And so we can maintain lower levels to have a good hemostasis. In the table, you have the distinction between, let's say, what they call lower dose and higher dose practice pattern in order to cover globally the need of different countries, because we have to acknowledge that the access to treatment availability is not the same worldwide, meaning not that patients should be treated differently, but just to recognize the minimum which is required to ensure hemostasis. We have to acknowledge that sometimes we have to accept a compromise in some situation where there is no large availability. However, what is really important and let's say needed everywhere is never to discontinue the treatment. So using a little bit less but continuously is much better than just giving a high peak maybe at the beginning and that not having the possibility to go on. So maintaining much stable and continuous coverage and detectable levels at a certain level is much better than just have very high peak and then nothing for some days. Of course, here you can see that usually the average duration of the postoperative treatment period in a major surgery is up to 2 weeks, almost, and much less, around 5 to 7 days for a minor procedure. There are also some minor procedures maybe requiring just a couple of days of treatment. So, if we were able, let's say, to answer all the questions of the planning, Something that is really important is also to look at other situations that may impinge upon the hemostatic, let's say, impact of the drug. For sure, inhibitors. So we are talking about patients without inhibitors, but we always should take into account that in a lifetime of a patient with hemophilia, inhibitors can come. And they can appear even in asymptomatic patients. So not necessarily we have symptoms. So it's a good practice to look and check for inhibitor patients prior to any surgery, just to be sure that there is no chance to have neutralizing antibodies. That may, of course, hamper the effectiveness of the replacement therapy. We also have to take into account that the bleeding risk of patients is not only related to hemophilia and then to the replacement that we are able to do, but there are comorbidities or even drug drug interaction, or let's say that there are drugs that may increase the bleeding risk, like non-steroidal anti-inflammatory drug, like some antidepressants impinging upon the ability of platelets to be hemostatically valid. And this should be taken into account, looking and, let's say, considering the bleeding risk of a patient. And then I already touched upon the PK profile. We should somehow have in mind that the theoretical recovery for factor 8 is around 2, and for factor 9 varies between 0.7 and 1. But each individual patient may have a different in vivo recovery, and also for the half-life. In general, we have the idea of for native factor 8, factor 9 to have around 12 hours for factor 8 and 18 to 20 hours for factor 9. But then we have to take into account which kind of drug we are using, because we know that nowadays we can use PK modified factor 8, factor 9 molecules. So we have to take into account the characteristics of each molecule, which always have been combined to the individual response of each patient. So about the treatment, which drug can be used to cover surgery? For hemophilia A, here you can see in the table, we can use desmopressin, which is an analog of the anti-natriuretic hormone, so vasopressin. And this drug is very useful in patients with mild hemophilia A. In the surgical setting, I would say that moderate patients do not really respond in a proper way to cover the surgical setting. However, desmopressin can be very useful for minor procedure in patients with mild hemophilia A. Why only minor? Because I would say that due to the risk of tachyphylaxis, I would not use upfront desmopressin for a major surgery. But we can consider desmopressin usage for a major surgery in the postoperative period. So maybe covering with replacement therapy the first 48 to 72 hours, and when the levels needed are a little less, and so we can even alternate the use of factor 8 with desmopressin. This can be also a scenario where desmopressin can be very useful. For some patients, you can even maintain levels in the normal range for some days. We have to take into account that not all patients can use desmopressin due to comorbidities. So let's say all patients with many cardiovascular risk factor or uncontrolled hypertension are not really the one to use desmopressin because of the effect of these the vasodilation that this drug may cause. And we should be taking into account that hyponatremia is a possible side effect in patients for repeated dosing of desmopressin. Then we have replacement therapy, and replacement therapy can be done with either standard half-life, so unmodified factor 8 molecules, or modified factor 8 molecules, and we have the group of extended half-life products. And then the blue bar that you see at the bottom, tranexamic acid, so meaning antifibrinolytic drug. They are really very helpful in the surgical setting as an adjuvant therapy to be combined with replacement therapy, because it really improves the quality of the clot that is formed, and also improve the time and the effectiveness and, to wound healing. For factor 9, we have no option as desmopressin for hemophilia A, so we just rely upon replacement therapy. And again, here we have standard and extended half-life products with the clearly evident really advantage of the extended half-life factor 9 products over factor 8 in terms of covering very long period. And also these impinge upon the scheme of repeating dosing during postoperative period, because we can somehow repeat the subsequent dosing even after 48 to 96 hours, something that which is not possible with extended half-life factor 8 products, for which at least you may prolong until 48 hours, but no longer than that. So the other point which is important would be the discussion with the anesthesiologist. The anesthesiologist and surgeon, they are part of the team together with the hematologist. So everything should be done together, and the discussion maybe should happen and occur, of course, before, when planning, to discuss which kind of anesthesia should be given. For some surgery, we know that we can do spinal anesthesia, so neuraxial anesthesia. In some situations, this can be at risk of bleeding, unless we are sure that we can really cover our patient hemostatically in a good way. For some situations, better to go for general anesthesia, not to incur in this bleeding risk. There are some peripheral blocks, that neural blocks, that can be done, not in the spine, but for the lower limb or the upper limb. They are, let's say, a little bit safer than the spinal anesthesia, and if the patient already received the coverage, they can be done without major risk. So always replace and ensure good hemostasis before any invasive procedure. This is the mainstay for any procedure also that the anesthesiologist should do. And always remember them that to control the pain, they should avoid, when possible, the continuative use and, let's say, the prolonged use of non-steroidal anti-inflammatory drugs. For sure, if one or two administration are needed at the very beginning and patients are covered, there is no big issue there, but the continuous use impinge upon platelet function, and these may somehow contribute to a bleeding complication. So how long to continue with the treatment? It depends on the type of surgery again. So we can have even up to 1 month for major surgery, not because of the surgery per se, but for some surgery we need to rehab our patients, especially for after orthopedic surgery. And so rehabilitation is as important as the surgical procedure for the outcome. And so we need to ensure that rehabilitation is done properly. And for this, we don't want patients to bleed, otherwise they cannot be rehabilitated. So that's why we need, with a sort of prophylaxis after the surgery, to cover them. In some particular cases, we can even just treat 1 day, or maybe not even without any replacement therapy. I'm considering, for instance, cataract surgery. If anesthesia is done with eye drops, this can be done without any replacement. And what about thromboprophylaxis, which is the other mainstay for surgeons and anesthesiologists to, let's say, reduce the thrombotic risk related to major surgery. Usually mechanical thromboprophylaxis is used because it's not impinging upon hemostasis, so with the elastic stockings. But in some selected cases, due to the possibility that we have to restore normal hemostasis with the drugs, some patients may need to be treated with low molecular weight heparin because they have other risk factors like obesity, diabetes, cancer, and these patients are not protected from thrombosis. One, because we are covering them, and so they have a normal coagulation in that given period. And second, because these risk factors, we know they are very relevant for thrombosis, and combined with the surgery, they increase the risk also in hemophilic patients. So in the end, I would say that having in mind all these, we can somehow have an anticipate which is the level that we want to cover that given surgery. We can calculate, let's say approximately, which is the dose to use to have a target level. So ideally that we have some formulas that we can use. Usually you can use the target level and the recovery that we know for that given patient. And considering the weight of the patient, we come up with a total dose. Of course, this is an indication, but if, as in this example, we come up with 3,200, of course, we will use maybe 3,500. So we wouldn't want to waste product. So we can approximate as the most ideal dose to use what we have in our hands. Important to check the factor levels before and after the injection. I would say that this was pretty much more common with standard half-life products. With extended half-life products, we have also the advantage that having more stable levels, at least after postoperative day 1 or 2, let's say it's not really mandatory unless we have the clinical suspicion of a complication to do it for every injection, maybe every 2 or 3 days, just to be sure that we are maintaining a good level. And just to give some practical tips, we can consider for a major orthopedic surgery that we would like to maintain to have a level around 80 to 100% to be maintained at least preoperatively and in the first 48 hours. And to do that, for extended half-life factor VIII products, we would need maybe a preoperative dose and maybe a lower dose after 12 hours. And this is not because the product is not effective, but because we want to avoid very high peak. Because if we want to overcome the 12 hours interval, we should go very high. And we know that very high level, supraphysiological level, may even precipitate a thrombotic event. So we can add a little dose after 12 hours, and then we can go for daily injections. And then maybe after the first week, even every other day. For factor IX is much easier because due to the very long half-life of such products, we may have a preoperative dose and then according to different products add something after 12 or 24 hours, but then we can even go for one injection every 24, 48 hours since the beginning, and then maybe also even have longer intervals between injection based, of course, upon the response, the clinical situation, and the levels that we get in the lab. For all patients, I would say that adjustment should be done on an individual basis because this is the best way to tailor treatment and also not to waste product, maintaining a good hemostasis. The postoperative period should be at least 1 month after surgery, but it's pretty much dependent on the type of surgery and the requirement. And also this should be done together with the surgeon because they can give us also their point of view of how the course until wound healing is going. And with this, I will hand over again to Yesim for a case report, and thank you for your attention.